Good evening. I'm sorry I've not been able to attend the meeting, but let me present my talk. I'm going to talk about acute vertigo for this August stroke meeting. Let me tell you about this 65-year-old man with an old left stroke who was on aspirin and telmisartan. One day he woke up feeling dizzy and unsteady, especially when he tried to get up and walk. So he went to his general practitioner and immediately the GP sent for admission. When he came to the hospital, the BP was 130 by 80, his pulse was 110, there was no neurodeficit. But when he tried to stand or walk, he would feel dizzy. So the CMO was confused, the houseman was confused. What is to be done? Do we do an MRI? Do we do an MRI angio? No, we just asked them to check the standing BP. And sure enough, the person had postural hypotension. His GP had rightly suspected that there was internal or gastric bleeding. And by evening, the person required 3 pints of blood and was lucky to have reached the hospital in time. Let's look at another patient. This was a 50-year-old man. He had 3 episodes of brief vertigo in the last 2 weeks, each lasting for just a few minutes, and they looked like any other attack of vertigo. There was no tinnitus or deafness, no dysarthria, diplopia, or any limb symptoms. He showed his GP and was given an anti-vertigo drug. Then he went home happily. But 2 weeks later, he came in with what is called a locked-in syndrome, and the patient unfortunately had this terrible state. He was quadriplegic. All that he could do was move his eyes up and down, and there was no other movement that he could.
वरती बघा
We do not
वर
want
बघा
this to happen. This is due to basilar occlusion,
काय
and there was the large impact C. Another young boy who came with attacks of vertigo. For 3 days, he was just getting attacks of vertigo, no tinnitus or deafness again. He went to the GP, who again gave, not the same one, another GP, who again gave him anti-vertigo drugs. The guy improved and even went for a picnic. But 3 days later, the picnic got over for both him and his
चक्कर
family.
म्हणजे काय होत
Now he came with
चक्र म्हणजे असं
vertigo.
चालताना तोल जात होता.
He was having
कुठल्या बाजूला
ataxia. He was having this gross nystagmus to the left. Finger nose ataxia, as you can
आता
see,
उजव्या हाताने
on
कर
the right. See here, right finger nose ataxia.
कर
His
मागे
MRI
बघा
showed a brain infarct. So just because the patient is young does not mean that you can relax. You have to be careful. And today I'm going to try and tell you when and how you should be careful about not missing a TIA or a stroke for simple vertigo, which you are thinking might be due to the ear. Posterior circulation stroke. This is an old 10-year-old article, but it was called a Cinderella disease because nobody likes it. People do not diagnose posterior fossa strokes as well. They do not have good imaging. We often miss small infarcts in the posterior fossa, and treatment has not been directed towards it. And there are not so many trials of thrombolysis in posterior fossa strokes. So when you look at strokes, two strokes which look like a stroke are what is called a stroke. But when it doesn't look like a stroke, then we call it a, when it looks like a stroke but is not a stroke, we call it a stroke mimic, like hypoglycemia, like a seizure. Then we have what is not a stroke and doesn't look like a stroke. So that is not a stroke. So maybe Parkinson's or any other thing, or demyelination. But then we have this dangerous thing which does not look like a stroke but is still a stroke, and these are called the stroke chameleons. And posterior fossa strokes are one of the most common causes of stroke chameleons. So you can imagine, they often do not even reach a neurologist. They may go to the ophthalmologist for double vision or for visual loss or even cortical blindness due to occipital infarcts. Somebody, when he gets vertigo, typically goes to the ENT when he might be having what we call a cerebellar stroke. Let us look at this. Therefore, the posterior fossa strokes misdiagnosis is much more common. If you see the NIHSs, they may even have a zero NIHSs, and the neurological examination can be deceptively normal. Therefore, we do not want to miss them. This was a recent study which showed that even supratentorial strokes, about 3.7%, may have acute vestibular symptoms, and you may have only vestibular symptoms in about 1% of supratentorial strokes. So the lesions are widespread, they are not necessarily in the vestibular cortex, but you have to keep in mind that supratentorial stroke can also come with vertigo. But today we'll be focusing on the various dizziness and vertigo presentations. Now, an easy way of trying to look at them is divide them into four syndromes. Is it an acute first time attack? We call it an acute vestibular syndrome. And we shall see that the most important thing not to miss here is a cerebellar or a brainstem infarct. Though, of course, the second cause is vestibular neuritis. Then you have recurrent attacks. If the attacks are recurrent but positional, then most commonly it is BPPV, and we'll not look more at that. You may get recurrent spontaneous attack. That means an attack which is not related to head movement. And here we have to think about, of course, migraine and Meniere's disease. But for today's talk, we have to remember that vertebrobasilar TIAs can come as recurrent spontaneous attacks. Of course, those who have chronic imbalance, we are not going to look at them because they are not due to stroke. So the acute vestibular syndrome. This is the guy who comes with the first attack of vertigo. They are typically very sick and they will not land up in your clinic. They are typically coming to the emergency department. And let us look at one such patient. This was a 82-year-old diabetic and hypertensive. He came with acute onset dizziness and oscillopsia. Everything was moving up and down for him. His BP was normal, speech was normal. He had a little unsteady gait, but he had a peculiar vertical upbeating nystagmus. If you see Leo, this is his nystagmus. He's getting upbeating nystagmus, more on looking up. यहाँ देखो मेरा Of course, they thought of a stroke and MRI was done, but MRI only showed old ischemic lesions. Sometimes an MRI can miss, therefore the MRI was repeated after 48 hours. Again, it was normal. Then the patient was asked to come and show me, and then we said no, in a posterior fossa stroke, you may not see an infarct up to 72 hours. So we asked them to repeat an MRI again the next day, and sure enough, now it showed the infarct. There was a pontomedullary infarct that was seen only at 72 hours. So remember, if somebody has got a suspected posterior fossa stroke, you may miss it if you just look at the MRI. Even a 3T MRI can be normal, and up to 1/3 such cases can be normal initially. So you have to repeat it at 72 hours if you suspect it. And up to 15 to 20% of such infarcts can be missed. There are various papers, you can look at them. Okay, so the most important thing you want to see is vestibular neuritis or cerebellar infarct. Now, when somebody comes with an acute first episode of vertigo, this is called the acute vestibular syndrome, and 1 in 4 of such patients can be stroke. Not all are vestibular neuritis, not all are vestibular or benign ear disorders. And how do you diagnose it? There is a simple test called the HINTS protocol. This is a very old paper. And I would ask you all to go and look at it. It is a freely available paper, 2009, Hints to Diagnose Stroke in the Acute Vestibular Syndrome. And basically, simple eye signs can distinguish reliably within minutes. Even an MRI can miss in almost 12% cases in this situation. But if you do these simple eye tests, you can diagnose it. Of course, these tests are not simple, but still I'm going to show you what they are. So the first test is the head impulse test. Now to understand the head impulse test, you must try to see what is the function of the vestibular system. When you give a sudden jerk to the head and you ask the patient to keep looking at one spot, if his vestibule on the right side is intact, when I turn his head to the right, his eye will still keep looking straight at that spot, and you will see that his he doesn't have to think. The message goes to his from his inner ear to the brainstem immediately, and it moves the eyes appropriately. If you jerk the head 30 degrees to the right, the eyes move 30 degrees to the left, and the person still keeps looking at the same spot. If, on the other hand, there is a defect in his vestibular system, when you give a jerk, the eyes will go along with the head towards the left, and then he has to do a corrective movement, which is called a corrective saccade, to bring the eyes back on target. Let us look at one such patient. This is the first patient. I'm jerking his head, and you can see I've asked him to keep looking at the camera. See that his eyes keep looking at the camera. This head impulse test is negative. It is. Now let's see what happens on the right. See, his eyes got dragged to the right, and he had to make a catch-up saccade to bring his eyes back to the camera. See there. So you have to try and look for this catch-up saccade. Of course, video that I've taken is in slow motion. So when you actuate, how it will look. This is the normal side, and this is the abnormal side. You have to look for this saccade. Try to practice the head impulse test in as many patients as you can, so that you get a feel of how to do it and what is a good test. Uh, then let's look at the hints. Stands for head impulse, that is the HI. N is the nystagmus. So the nystagmus has to be horizontal and unidirectional. It must beat only in one direction. That is the typical nystagmus of vestibular neuritis. Of course, even somebody with a nystagmus which is unidirectional can still be stroke, and that is why you need the remainder of the hints protocol. You need the head impulse and you need a test of skew, which we shall see. But if the nystagmus is any other type, so if it changes direction, if it is vertical like in the patient I showed first, or if it is only torsional, then it is not a ear disease, it is not vestibular neuritis, you must think of a stroke. So this is the patient where you can see that his nystagmus is constantly beating to the left. Whether he looks to the right, he looks to the left, the nystagmus does not change direction. But in this you can see when he looks to the left, nystagmus beats to the left. When he looks to the right, the nystagmus beats to the right. This is stroke. Then we look at what is skew deviation. Normally both the eyes look at the same target even when one is covered. So when you cover this, if you see, if the eyes are skew, one is up, one is down, you will see that when you cover one and the other eye, the uncovered eye will move up and let me show you this again. Yeah, so this is a patient where I'm actually doing the test. Okay. When I cover it, you can see the eyes going up and down. So this person is not looking at the same spot, and therefore his test of skew is positive. Okay. This is in slow motion. You can see the eyes move up and down. When I cover it, that eye goes up. So the test of skew. So these are the three signs: direction changing nystagmus, which you may find in 20% cases, skew deviation, which you may find in 25% cases, and the head impulse, which should be normal in central cases but abnormal in vestibular neuritis. If you have a combination of all three, it is 100% sensitive. You will not miss a stroke, and it is almost 96% specific. Let us look at another patient of who's come with a first attack of vertigo. She is a 55-year-old lady, acute onset vertigo. She did have a history of migraine in the past, but no other risk factor. And when we saw nystagmus, it was unidirectional, beating to one side only. Hearing is normal. So you can see nystagmus, it keeps beating to the constant, whatever you may do. So to the right side beating nystagmus. Now let's see the impulse test. On the right, it is normal jerk. To the left, you can see there. He has a left vestibular neuritis. Then we come to the hints plus. So if somebody has a hearing loss which is acute in onset or sudden tinnitus with vertigo, that is dangerous and that is not an ear disease. If it is a sudden onset, think of a central cause. So sudden hearing loss with vertigo is greater risk than sudden hearing loss alone or sudden vertigo alone. If you have a combination of sudden hearing loss along with vertigo which is acute in onset, that is a high risk of having a stroke. So somebody come with acute hearing loss, often is viral, acute vertigo often is viral like vestibular neuritis, but sudden hearing loss with vertigo often is stroke. The hints evaluation needs learning and practice, so I would exhort you to keep practicing every day. But what various studies have shown is that in the emergency department, when they have checked the emergency physician checks, most neurological findings have low sensitivity and high specificity. So they are not sensitive. So if you try to look for finger nose ataxia or dysarthria or sensory loss, it is not sensitive for posterior fossa stroke. Hints and the hints plus have very high sensitivity, but it requires to be done by trained physicians, and often that is unfortunately not there. So there is a simple rule of thumb for you. This study, the diagnostic accuracy of truncal ataxia and hints as a cardinal sign for acute vestibular syndrome. It's a very good paper made by my friend Sergio Carmona from Argentina. So the basic rule is even on the phone you can use it for diagnosing. If the patient says he cannot even stand without support, it has to be a stroke. A vestibular neuritis can always stand without support. If the person says there is no imbalance at all, then it is unlikely to be a stroke. But if the person cannot walk without support, you have to be careful. It is likely to be a stroke and you need to do a proper evaluation. So if the person says there is no imbalance at all, you can be relaxed, it is not a stroke. But if the person cannot stand without support or cannot walk without support, then you need to examine properly. When these patients of stroke which look like vestibular neuritis are also called vestibular pseudoneuritis. So how do you treat it? If they come to you in time and if you are sure of your hints testing, thrombolize them. If not, do the routine stroke treatment, antiplatelets or whatever if they have come later, and look for a large infarct as they might need surgical decompression. Large cerebellar infarcts often need surgery. Then we come to the second group, that is the spontaneous attacks. So here the most dangerous one is vertebrobasilar TIA, which is the most dangerous. The most common is vestibular migraine, which we are not going to look at. And of course, the most overestimated is Meniere's disease, which we will again not look at. Most of the time, these patients come with a history. So when they come to you, they do not have the attack. But sometimes you are lucky to witness an attack when they get in front of you. So this 60-year-old diabetic and hypertensive was getting recurrent attacks of vertigo very frequently, lasting for 5 minutes, and he did have an attack in front, and we saw that he had this nystagmus beating to the right, spontaneous,
5 मिनट हो गया,
which cleared off in 5 minutes.
कितना टाइम चक्कर था?
When you get this sort of spontaneous attack,
लेफ्ट को देखो,
you have to look for a vertebrobasilar T. And sure enough, his MRI showed small patchy infarcts in the brainstem and cerebellum, and he had a bad basilar stenosis. He was given double antiplatelet and his BP and sugars were controlled, and luckily he has been all right for the last 3 years. This is what the patient where the TIA was missed. We don't want to happen. The long-term syndrome was the same one. Okay, so always keep TIA at the back of your mind, especially if it's an older patient, if there's a stroke risk, even if there are no other symptoms, only vertigo, think of TIA. Don't relax. Of course, don't go overboard. Every patient with vertigo, we don't want to do MRI angio and all those things. It has to be attacks which fit in into that period, that is less than 5 minutes attacks, older patient and with a stroke risk. Uh, as I said, the diagnosis is based on history because it is rare to see. And typically you hear the history, you don't see an attack. So one way of seeing an attack is tell the patient to record. You teach them how you want them to record the video, and it can be very useful. When they get an attack at home, you tell them, this is how I want you to take the video and send me the video. And one of my patients was getting attacks of vertigo. When we examined him, there was nothing. He also had tinnitus and deafness, but even Meniere's migraine can have that. So I had no way of knowing what it was. We asked him to record the video. He recorded it, and this is uh, his nystagmus done by him at home after teaching. He had nystagmus beating to the left, and the next his nystagmus was beating to the right. When you get this pattern of nystagmus beating one side and then the other side the next day, this is very typical of Meniere's, and we could diagnose Meniere's confidently with this nystagmus. So when do you consider TIA? If there are multiple risk factors like hypertension, diabetes, atrial fibrillation, or vertebral artery stenosis. See the ABCD2 score. If it's more than equal to 4, think of it. When there is a new headache or neck pain, think of a TIA. If the person is unable to sit or is losing balance, think on the history also during the attack, think of a TIA. And of course, if you examine and find any signs, or if the MRI shows any, even a tiny infarct or a bad vertebral or basilar stenosis, think of it. Isolated transient vertigo due to TI is a real challenge. 21% of vertebral TIs may come with isolated vertigo, and almost 8% of all patients with posterior circulation infarct may have had vertigo in the past, which was ignored. We did a paper. I was lucky to be a part of that during the pandemic. And so we tried to see how do you examine patients virtually when on the phone. And what we saw that you could do recorded videos, you could do online consultations. And when do you admit a patient? If the person has a first attack, they must get admitted and go and get checked to make sure it's not a cerebellar stroke. If they are old, if they have risk factors also, if they have any brainstem or cerebellar signs or symptoms like slurred speech, dysarthria, dysphonia, dysphagia, then of course they should. If the person is unable to walk or sit without support, yes, they must. And if they have headache in the first attack of vertigo, they must get admitted. So to summarize, my take-home points are vertebrobasilar TI can present as isolated vertigo, sometimes for months. Be careful and do not miss a stroke in the first attack of sustained vertigo. When somebody comes with an attack of vertigo lasting more than 24 hours for the first time in their life, be careful. It could be a stroke. Even big strokes may not have much signs, no finger nose ataxia, nothing else. They may only have this nystagmus which looks like vestibular neuritis. They may not even have nystagmus, they may have just unsteadiness of gait. If the person cannot stand or sit without support, he cannot leave, he needs investigations. If you find skew deviation, that is a bad sign. If you find direction changing nystagmus, that is a bad sign. Head impulse sign is necessary to diagnose if you want to diagnose vestibular neuritis, it is necessary. But you may find a positive head impulse sign also in stroke. Therefore, you have to be careful. You have to do the remaining part of the HIDS protocol. Thank you, and I hope that you all start doing the head impulse test and look at the eyes carefully of your acute vertigo patients and do not miss any strokes. Thank you.